No, you can boost. You can use the TBI and boost to the brain, as we used to do with ALL in the past.
Now it will be some sort of CNS therapy rather than TBI. I mean, if we never go higher dose than the TBI convention, then TBI will probably is another issue.
Okay.
Maybe TBI is not enough for improving the performance.
Any other questions? Dr. Mrs. Frank, please.
Because the aim of this study is to eliminate whole brain irradiation, and the student can break from the eye, and if you go to involving whole brain irradiation again. So, to my mind, that the importance of this study is to rule out whole brain irradiation.
Okay. Other questions?
Thank you so much for this presentation. I just want to ask you about the dose and the time interval between high-dose methotrexate and high-dose RSC. Because there has been a lot of debate about this. Of course, I know that less than 1 gram methotrexate is no more valid. But what's the approximate average dose usually used regarding the methotrexate and the RSC, and what's the interval between both of them?
In most of these protocols, methotrexate was used at a dose of 3.5 gram per meter square day 1, and then day 2 and day 3, you use 2 gram per meter square of RSC every 12 hours, so it's 4 doses. And rituximab, it's twice during this course, and it's a 3-weekly cycle. But this is different from the high-dose sequential chemotherapy. High-dose sequential chemotherapy, it's a cyclophosphamide 7 gram per meter square. Okay, and then you do the mobilization and stem cell collection, and then you give the high dose RSC with the stem cell support. It's different from the regimen for induction. So the induction regimen, they are in day 1, day 2, day 3. For the intensification, it's cycles every 3 weeks, within 3 weeks. Yeah.
Thank you.
Thank you so much. Excellent presentation. So how do you give the methotrexate? Because we used to give the bolus part and then we give it continuous infusion over 22 hours. But I think for CNS you need to do it a little bit shorter so that you have a...
For the intensifying, most of these regimens, indeed, it was 3-hour infusion. Yeah.
And what
The half hour and then the continuous infusion, we use it in other regimens, but not in the one I presented today.
And toxicities?
As long as you follow carefully the methotrexate level, creatinine, and do the leucovorin rescue, it's fine.
Last question.
Thank you, Mr. Safa, for this talk. I'd like to ask about the rule of autologous transplant up front. Are you keep it for the high-risk patient according to the risk stratification you just shown, or apply to the whole category of patients?
I would say according to our clinical practice, we do not apply it to all patients. We apply it mainly for patients who have extra CNS disease, so concomitant with systemic disease. So these are mainly the patients who should receive upfront autologous stem cell transplantation.
So this is not a primary CNS lymphoma?
Yeah.
Okay, now we move on to the last presentation, which is going to be given by Professor Tarella about novel targets of T-cell non-Hodgkin lymphoma. What are the new options in relapsed refractory non-Hodgkin lymphoma?
Thank you. First of all, let me thank the organizer for this invitation. I'm really glad and I would say excited to be in such an important city with such a long and relevant history for all of us. And I want to apologize for having missed the debate on the multiple myeloma, but I was sure that Dr. Montefusco would have covered all the issues issue much better than what I would be able to do. My presentation is in the treatment option in relapsed refractory non-Hodgkin's lymphoma. I have prepared a presentation a little bit different from what I have heard from the previous speakers, trying to address what happened in the real life and which might be the treatment option and the day-by-day management of our relapsed patient. And in the real life, I decided to start with this very old figure that represents the incidence of non-Hodgkin's lymphoma with the prevalence of diffuse large B-cell lymphoma and follicular lymphoma. And I will focus my attention mainly on these two most frequent subtypes. Talking about the real life, we have performed very recently a sort of long-term survey. Actually, it was a 30-year survey on lymphoma patients that we have managed at two institutions in Torino and Bergamo. But the incidence is more or less similar to the one we observed previously, with a difference regarding the diffuse large cell lymphoma that were much more frequent in our series. Probably this reflects the fact that the most aggressive patients are referred to specialized centers. And as I said, most of my presentation will be focused on follicular lymphoma and diffuse large B-cell lymphoma. And what we have seen, and this is the first message that I want to tell you, is that the primary refractory disease is the most important problem while managing both diffuse large B-cell lymphoma and follicular lymphoma. You can see from the survival curve, those responding at the induction treatment have a very prolonged life expectancy, around 20 years, compared to more or less than 1 to 2 years for those with a poor response to the first line therapy. And this is the first message. The first shot, the initial treatment is crucial for the management of our patient, trying to reduce the risk of refractoriness and also the risk of disease recurrence. How is the size of refractory disease? First of all, regarding follicular lymphoma, overall 13% were not responsive to the first-line treatment. But as I said, our survey covered both the period preceding the introduction of rituximab, and in this period, the percentage of refractory disease of refractory patient was definitely higher, 20%. Now, in the rituximab era, the proportion of follicular patients not responding is much lower, ranging around 80%, definitely lower compared to diffuse large B-cell lymphoma, intermediate level for mantle cell lymphoma, while T-cell lymphoma have the highest proportion of primary refractory disease. That is probably the reason for the poorer outcome compared to B-cell lymphoma. So let's go ahead with the follicular patients. Overall, 597 follicular lymphoma patients were followed, and again, as I said, the difference in this subtype of lymphoma was of this size, not reached the overall median survival for follicular versus strictly 7 years, the life expectancy for those not responding. What happened in the subsequent part of the study, besides the poor outcome of the primary refractory, what happened to the responding patients? So more or less 50% of the patient had subsequent disease recurrence, 45% exactly. But this is another important aspect. Roughly 50% of follicular lymphoma patients remained in continuous CR. So this is against the old story that all follicular lymphoma patients sooner or later do have disease recurrence. It's against the idea that follicular lymphoma is a chemo-resistant subtype. More than 50% of responding patients and approximately 50% of the whole series had a prolonged survival in absence of any recurrence. What about the remaining part, those with the 45% with recurrence? Are all the same, these patients? Should we manage all in the same way? No, the answer is no. And to support this idea, I want to show you a recent study performed by the cooperative group in the United States, coordinated by Casulo. She presented this data at the ASH meeting, but then the data have been recently published. They followed again a large series of follicular lymphoma, and they observed that approximately 20% of these patients had a disease recurrence within 2 years since treatment, since the start of treatment. This was true in the Oliver Press presentation, was similar observation in the Rummel study with bendamustine, and again also among patients in the previous study there was always at least 20% of patients with follicular lymphoma recurring within 2 years of treatment. And they said that probably this represents a particular subtype of follicular lymphoma patient. Why a particular subtype? Because then, as we did with our primary refractory, they wanted to evaluate the survival. This is the survival of patients with disease recurrence within 2 years. And you can see the difference between the remaining part of the follicular lymphoma patients. So this figure, this survival, this difference in the life expectancy demonstrate that not all recurrence disease in follicular lymphoma are the same. And indeed, in their presentation, they say that this is a distinct subtype of patients that require, that need a distinct management compared to the other follicular lymphoma patients. In line with this idea of a different subpopulation of patients, those with an early recurrence and those with late or never recurrent disease, is this other presentation, again sort of multi-center study, both American and European. This is compared to the previous study in a more limited number of patients, only 900, but it's a prospective studies. Again, they wanted to evaluate the long-term outcome of follicular lymphoma. This is the long-term survival. The black line with the dots are the population of follicular lymphoma. The red line, I don't know if you can see, the red line represents the life expectancy of the normal control population. It's almost superimposable, slightly lower for those follicular treated with chemoimmunotherapy that probably reflect the higher risk for this subpopulation. But then they wanted to look at the long-term survival according to the event-free, according to the risk of relapse. Again, for those patients who had an event, usually a disease progression within 1 year of observation, this is the survival. Definitely low, definitely poor if we look at the remaining population. And again, our study, the study by Casullo, and this last report, all are in line that we have to manage two different populations. Those who are quite responsive, who have a prolonged CR, and those who have or a primary refractory disease or an early disease progression. So this is a very high-risk population. This subtype of patients deserve a different approach compared to the usual follicular lymphoma patients. And which is the best approach for this subtype? At the moment, the best management, the best reliable management remain the intensified treatment with autologous transplantation. Several papers, several studies have demonstrated both the feasibility and the efficacy. I don't want to review all the data on the autologous transplantation in follicular. I just wanted to present this study, which I believe is the most clear documentation of the efficacy of autologous transplantation. Is a study done by the French group, and they observed the long-term outcome of patients with follicular lymphoma recurring following a uniform treatment. They found that those patients who have been managed with autologous transplantation did definitely better compared to those managed with, let's say, conventional chemotherapy, both in terms of event-free survival and overall survival. But one aspect is how is effective autologous transplantation in those patients who have previously received rituximab. And this diagram, this event-free survival, concern only those patients who had disease recurrence following a previous treatment with rituximab. And again, the dotted line, the transplanted patients had a definitely better outcome. And finally, also those with primary refractory disease did definitely better if managed with autologous transplantation. In our experience, we have been using for several years, we are still using this very intensive chemoimmunotherapy approach with high-dose etoposide, high-dose cytoxan, rituximab, mobilization, and then autologous transplantation. In our experience, we evaluated the outcome of 125 relapsed or refractory patients. It's a mixture of autologous transplantation. It's not there are no selection on the time of disease recurrence, but usually we deliver autologous transplantation in those with an early disease recurrence, and this is event-free survival, which is not bad, considering the study is also multi-center evaluation, but should be improved. And what can we do in order to improve our results? Several new targeted drugs. And here is the list of all the potential drugs that we can consider for the management of relapsed patients. Lenalidomide, PI3 kinase, BTK inhibitor, BCL2 inhibitors, inhibitor of nuclear export, novel monoclonal antibody, immunomodulator. A lot of studies have been presented using these different new drugs, none of the study presenters have selected the real high-risk patients. Among all these drugs, what probably has been considered the most suitable for follicular lymphoma are the inhibitor of the PI3 kinase. PI3 kinase is signaling, has a role in the signaling transmission for several pathways that are activated in B cell, in the B cell, in normal B cell, and are abnormally activated in the malignant counterpart, in particular in indolent lymphoma. You know very well the first report with the PI3 kinase delta inhibitor, the idelalisib. They studied patients with repeated disease recurrence. Most of the patients were follicular lymphoma. They did not select those at high risk. Actually, the fact that this patient had repeated disease recurrence suggests that they had a sort of responsive disease. But anyway, as a single drug, the drug proved to be effective with an overall response rate around 50 to 60% in the whole series and also in the patients with follicular lymphoma. How were the survival curve? You can see that no plateau is obtained. It's important that the drug was effectively used alone, but cannot be considered the breakthrough, cannot be considered the solution for the management of recurrent disease. So, in our idea, not only in our idea, we are facing a very difficult disease when the patient has a primary refractory disease or an early disease recurrence. For these patients, at the present, the standard approach should be intensified treatment, and we have to try to improve the results by adding new drugs. The new drugs that are under study in this view are lenalidomide and idelalisib, and I believe that at the moment probably idelalisib is the most suitable drug to be combined in a program aimed to arrive to an intensification with autologous transplantation. Similar issue and similar conclusion can be done regarding diffuse large B-cell lymphoma. Again, probably more than in the follicular lymphoma, the primary issue is primary refractory. Those who are not responsive to the first-line treatment is the main problem in the management of diffuse lymphoma. Again, here are the survival curve for these two subtypes, those responding and those with fully refractory or early disease progression. What about the late disease recurrence? It's a minor problem. And to support this concept, I want just to show you a recent result that we obtained in a multi-center study comparing R-CHOP versus R-HDS in high-risk patients. I don't want to review this data, but I like to show you the disease-free survival curve. As you can see from this curve, both in the line with R-CHOP and the R-HDS, there are few failures following the first year of observation. Most failure, virtually all failure, occur during the first year of treatment, during the first year of observation. So again, the problem is not the management of the few late disease recurrence. The problem is the management of those who are not responding adequately to our initial treatment. Refraction displayed either fully refractory or early disease response, and unfortunately, at this time, even autologous transplantation have a minor role in trying to salvage this patient. This was clearly demonstrated by the study, by the coral study, again a multi-center effort to evaluate the efficacy of the DHF versus ICE with rituximab as induction treatment, then followed by peripheral blood collection and autologous transplantation for those responding to treatment. A lot of patients have been enrolled in this global study, 400 patients. The outcome was almost the same for DHF and ICE, 56%, the overall survival for both arms, 42 and 45, the progression-free survival. This is not the aspect that is important to our presentation. What is important is the comparison in the outcome according to the time of disease recurrence. Yellow and blue are the two lines, ICE and DEC, no difference. Yellow and blue instead are the two subpopulations previously treated with rituximab, yellow, and previously not receiving rituximab. Why the difference in these two curves? Only the time of disease recurrence. If the recurrence occurred within 12 months, those who have been previously treated with rituximab have a poor outcome even with autologous transplantation. Anyway, if you ask me which is the standard option now for a patient even with primary refractory, I have to say at present high-dose therapy is still what we have to offer to our high-risk patients. And this is supported by several observations. Not the last is this study by the EBMT showing the overall good outcome following autologous transplantation in a large series of more than 400 patients. What is important, those patients receiving autologous transplantation has a longer CR2 compared to the duration of CR following the initial treatment. But anyway, we have to do something because it's still an unmet need, the management of those patients with primary refractory disease. And again, we have to do something by adding new drug. The same drug that I showed you before for the follicular lymphoma can be considered for the diffuse large B-cell, but probably lenalidomide is the one which has been evaluated more extensively in diffuse large B-cell lymphoma, not only as a single drug, but also in combination with chemotherapy. Probably one of the most relevant results have been obtained by the group of the Mayo Clinic, coordinated by Witzek, and they recently presented this study showing the feasibility of the combination of lenalidomide at the standard 25 milligram with R-CHOP in patients with high risk, presenting with high risk histological subtype, the activated B-cell lymphoma. And in line with this presentation, and in line with what I have mentioned before, trying to improve the salvage treatment, there is a recent experience with lenalidomide. which is the Revlimid, the so-called R2 program combined with the ICE, the one that we have seen before in the CORAL study. This is a sort of phase 1 study. We can't say about anything about the efficacy. We only say that we have space to include other drugs in our salvage treatment, and probably the most suitable drug in diffuse large B-cell lymphoma is lenalidomide. That should be added with caution. That should be considered to be combined at a different dosage compared to the dosage when the drug is used alone. One more question is regarding allogeneic transplantation, and regarding allogeneic transplantation is still a treatment option. However, for the time being, as I said, since the beginning of my presentation, the first option remains the autologous transplantation. The allogeneic transplant should be preferentially considered for follicular lymphoma patients, and in this setting, probably its place is in the rescue for those failing also the autologous transplant. And this is the indication that derived from a consensus project from the EBM team, where again they proposed the autologous SCT as the first option and allogeneic transplant in case of failure following autologous transplantation. So this is my conclusion. We have a different subtype among B-cell lymphoma, especially among diffuse and follicular lymphoma. Those who have a primary refractory disease or an early disease recurrence, auto-SCT remains the most suitable salvage. Novel drug should be included in this program, and among novel drug, PI3K inhibitor for follicular lymphoma and lenalidomide for diffuse large B-cell lymphoma are those that I consider most suitable for this program of combination with high-dose treatment. Thank you for your attention.
Thank you very much, Corrado, for the very large and comprehensive review. I had several questions to raise to you, and probably from the audience too, but I think we run late with the time, and unfortunately I have to close the session and to switch to the following one. Thank you very much again. So let's switch immediately to the next session, which is starting right now, and which is scheduled at 5 o'clock. And NPD and CLL, and I want to invite the first speaker, who is again from Italy, Professor Michele Baccarani, to have his presentation. We have to switch.
Can I initiate? Good afternoon or good night to everybody. First of all, let me thank very much the society and everybody who was involved in my invitation. It is a great pleasure and it is a great honor for me to be here in this very ancient country to discuss with you the optimization of the treatment of chronic myeloid leukemia. Maybe can you change because it is not necessary to screen. Okay, but I can go on with my disclosures. But I would like to have a full screen if it is possible. This is not to show you my disclosures and to alert you. Thank you. I'm not familiar with this. So, okay, thank you very much. Thank you very much. This is not just to alert you on my contacts with many companies, but also to acknowledge all these companies, and particularly Novartis, that was the first company, because of their outstanding contribution to the treatment of chronic myeloid leukemia. Let me remember to everybody that until not so many years ago, chronic myeloid leukemia, with few exceptions, was a killer. The disease killed everybody. Now, with some exceptions, nobody is killed by chronic myeloid leukemia, with some exception. And now what we are discussing is not, I'm not bringing recommendations. I'm not bringing guidelines. I would like just to discuss with you what we should do to make a proper use of the drugs that were made available by these companies, how to optimize the treatment, how to make the treatment cost effective. And I'm afraid that I will bring more doubts than recommendations. Switching. Switching is a popular term indicated when situation when we move the treatment with the DKI, because all chronic myeloid leukemia patients are now treated with the DKI, from one DKI to another DKI. And switch, so it is always an option. It depends on the doctor, how to decide. And of course, we can have two types of switching. In case of warning or suboptimal response, in order to achieve an optimal response, the so-called early switch. Or in case you want to achieve a deeper molecular response, so as to bring the patient into treatment-free remission. This is a definition of the response according to European Leukemia Net. It's the last version that was dated in 2013. And I expect that there will be another version in 2016. And the response was defined optimal, and everyone is happy when the response is optimal, and every doctor is happy because he or she knows what they should do. Continue the treatment. Failure, the definition of failure means that whenever you can, you should change the treatment. Nobody likes warning or suboptimal response. But there is a gray zone between black and white. Optimal is white, failure is black, and there is always a gray zone. And no doctor likes this gray zone also, because it is up to him or to her to take a decision if and when to switch the patient to another treatment. This is another old slide showing very clearly, this is our Italian doctor, showing very clearly, can you hear me? Yes. Showing very clearly that suboptimal is not as good as optimal. And this is obvious, I would say. But the point is, if we switch the treatment, will the response of these patients become optimal? Because that's a point. Not to acknowledge that suboptimal is not as good as optimal. Suboptimal response, whether you use the term suboptimal response or it covers a gray zone between optimal response and failure. It is time dependent. What is warning at 3 months could be a failure or optimal at 6. And we believe that all patients with suboptimal response or warning are eligible for investigational therapies. But there is a reasonable expectation that if you move to another treatment, you switch. It will be good for the patient, but it is not known if switching to another therapy may result in a better outcome. And also the enrollment of suboptimal response is, I would say, technically difficult. So it is rather difficult to will answer to these questions. There are at least 6 and more, I must confess, at least 6 very important studies that have reported a superior outcome in the patient treated first line with imatinib, nilotinib, dasatinib, or bosutinib, and in TKI to achieve an early molecular response. And you know the early molecular response means initial transcript level equal less than 10% at 3 months. If you look at progression-free survival, PFS, and overall survival, OS, it is irrespective of the TKI. It is better for the patients who have achieved an early molecular response than for the patients who have not achieved an early molecular response. These are data. And this is a summary of several important studies which are listed in the left of the slide of the percentage of patients who achieve an early molecular response. With imatinib, the early molecular response rate ranged between 64 and 76%, and the median is 68. And if you take nilotinib first line, or dasatinib first line, or bosutinib first line, it is about 20 to 25% more. So if you use second generation TKI from the very beginning, not if you switch, if you prescribe the second generation from the very beginning, you achieve more early molecular response. There is no doubt. And this is an example from one of the famous studies, the end studies, where imatinib were compared with nilotinib. And with nilotinib, the early molecular response rate was 91%, and with imatinib, it was 67%. And more. If you use from the very beginning, not if you switch. If you use from the very beginning in nilotinib or other second generation TKI, the probability of achieving a deep molecular response, such as NR4.5, is significantly higher. You see, whether you use nilotinib or dasatinib or imatinib, the prognostic value of the early molecular response is identical. The patients who achieve an early molecular response, they do better than the patients who do not achieve an early molecular response. And if you look at the proportion of patients who will achieve a deep molecular response, whether you use imatinib or nilotinib, and it will be the same with dasatinib, achieving an early molecular response predicts very significantly for achieving a deep molecular response. And you know that achieving a deep molecular response later on is important because it makes the patients eligible for treatment-free remission. So since early molecular response at 3 months predicts the rate and the depth of subsequent molecular response, predicts progression-free survival, predicts overall survival, should be changed. The TKI should be switched. If at 3 months the cerebral transcript level is still more than 10%. And number 2, since a deep molecular response is required for treatment-free remission, should be changed. This is the second question. The TKI, if after 1 or 2 or 3 or 4 years, the cerebral transcript level is still more than 0.01%, that it is the level of MR4. This is open for discussion. And there are 2 different points of view concerning the early switch. One point of view from the United States, from America, is the point of view of the NCCN. And they concluded that since early molecular response is obtained more with second generation TKIs first line, an early switch from imatinib to a second generation TKI is expected to be also convenient. And this is a rational expectation. But please remember that this is an expectation. And the expectation is different from evidence. European Immunity was more conservative than America. For once, Europe was more conservative. Because at the point of view of European Union Act was that there are no studies, that there are no data showing that the switch is convenient, and if so, how much. And of course, if you switch very early, there are some concerns. But I think that one important concern is, you can read in the last line of the slide, one PCR test may not be sufficient to mandate the treatment change. And we would like to have a confirmation of the data. And as there are studies testing the early switch, no, there are no studies testing prospectively the early switch. What I'm showing to you is the design of an Italian study called SUSTRI. This study will initiate in Italy very soon. It has already been approved, but the first patient has not yet been enrolled. And this will be a randomized study in patients with early diagnosis, chronic phase, chronic leukemia. The patients will be randomized to receive nilotinib or to receive imatinib. And the patients who will be randomized to receive imatinib will switch to nilotinib in case not of failure, which is obvious, but in case of non-optimal response. And please notice that the end point of this study is not measure molecular response, is not deep molecular response, is not survival, is the proportion of patients who will become treatment-free remission. Because this is the goal of the treatment in the next 5 or 10 years. Can we trust how much? Can we trust the molecular biology to decide of the treatment? Of course, we all use real-time quantitative PCR. Cytogenetics is going to be forgotten. But still, after 20 years or 25 years, with real-time quantitative PCR, we have some problem of standardization. And let me show a few slides showing the top right, that in the same labs or in standardized labs, there are variations in the appreciation of the patients with early molecular response or without. So some patients can just, by chance, become early molecular response or not early molecular response. You see on the top right. And the same is true, is even more true, as far as deep molecular responses, measured molecular response is concerned. So, even if the labs are well standardized and optimal, at both extremes, it may be difficult to establish exactly if this specific patient got an early molecular response or a measured molecular response, and even more if you look for a deep molecular response. So, I think that the lesson from this is that we should continue to use quantitative PCR. Yes, but we should do more tests. And this is clearly shown by Australian data and by German data, showing that the dynamics of the kinetics, as you write, of early molecular response may be more important, is more important than the molecular response at 3 months. And this is obvious. Because if you have 3 months, so do molecular testing, not only 3 months, 1 month, 2 months, 3 months. And somebody or many will tell me, but this is expensive. And I will answer that one test is less expensive than 1 day of treatment. So if you test more, you make a proper use of these very expensive drugs. What about the late switch? This is an example. This has been published. The CMR, where patients were optimal responders to imatinib, were assigned to friend to continue imatinib or to move to nilotinib, to a rather high dose of nilotinib. And to make a long story short, this study was rather successful, not completely successful, showing that the probability of achieving a deep molecular response was greater, was higher, than if the patients were assigned to continue to receive nilotinib than imatinib. So a late switch. Now this was, I would say, a clinical study. And now there is a more important study which is run in Europe. It's called ERST-PATH. And again, to make a long story short, this is a rather complicated design. This is a single arm study where optimal response to marketing are switched to meloxicam. Then they are treated with meloxicam for 2 or for 3 years because it is very